and we'll ask him to rejoin the table and open it up for questions. Susan, I'll start. So when we go back to the Alive cohort for drug users in Baltimore, it started in the 80s all the way through the present day. There were special arrangements made with the police to create a safe zone for drug users to exploit the services that the Alive cohort was offering, which were very much in the risk reduction, life-affirming spirit of your Spark study. What is your arrangement with the Baltimore Police Department in terms of running this program? Because you've highlighted the issues of harassment and even abuse of sex workers by police. What is it that you're doing to keep women safe in Spark?
Right, thank you for that. And just to say, there are a few bad actors. There are a lot of good. I mean, Baltimore, as you know, is a really intense city. You can only imagine to work. Cops work alone in cars, which that myth, if you close your eyes and see any TV show where there are two of them, it is not the case, which is why they talk to our researchers so freely, because they usually don't have people in the cars. You know, the neighborhood knows that we're there. We go to community meetings monthly. Barriers were more from the community association, who was nervous. We, of course, end up being next to the new microbrewery and a new cafe on a block on a street that's been trying to gentrify for years, and when we finally found our spot, they gentrified. The police are fine that they're there. We met with the major. Interestingly enough, last week they came showing a warrant on the door for a woman they had heard was a client there, and we don't have to let them in. We did not let them in. We've talked to the general counsel, who knows me well, at Hopkins. They didn't have a warrant to search the premises. There was no way we were going to let them in, and because it would make other people feel unsafe. So we have an understanding, but a few cops have come in just to see our services because they've heard about it, but we really try to maintain the physical space, that of safety.
Thanks so much for your talk. I have a really specific question. In your cohort of like 239 women, at the baseline you report 5% HIV prevalence, but then you go on to follow that cohort for, I think, 400 days, and you see this remarkable STI incidence, but you don't talk about HIV incidence in this graph. Do you?
Because it was very low. I think there were 5 women that had incident HIV among the CIS cohort. So, and true, we should have put that there, but it was quite low relative to the STIs.
How do you account for that? What's your hypothesis?
You know, it's complete networks. It's not in the pool. I think of the people with whom they're having sex. We likely, it's interesting, as the fentanyl epidemic and the overdose epidemic becomes more fatal in cities like Baltimore, we have a lot fewer women who inject drugs. It's the lowest. It's like half the women now in this next cohort of all the people that use drugs. So I think a lot of the risk probably from HIV was conferred from injection, but that's being reduced compared to the trans women whose HIV rate was like 46% prevalent.
Do you think their clients could have been on HIV treatment, living in that community? In other words, this is a really important aside. Could they have been, because I doubt if they're all getting PrEP, or something like that. The women aren't getting PrEP.
So the women are now from Spark. Some of them. I think that they were HIV negative. We don't know. I can't speak about, we haven't done work with the clients. It would be unlikely that they were virally suppressed through treatment from the prototype that we know who's their typical client.
Hi, good morning. Thank you so much for your presentations, and thank you for the work that you're doing, and for giving us new language, for looking at some of these most difficult things to accomplish in trying to reduce the risk of STIs and HIV. My question has to do, and what you're doing is hard to implement and certainly hard to evaluate. And from the time that you're beginning the process of looking at these facilitators and barriers and trying to understand these contextual factors, to looking at incidence of its impact on incidence of STIs and HIV, have you been able to identify along the way what are some indicators that you want to monitor and look at for success? Because sometimes it's hard to look at the link between intervening on a structural level and its impact downstream, I guess it is. So have you been able to figure that out a bit? And then my other question has to do with adolescents. Both of you gave examples of women, or in yours, Kim, with the intersection of incarceration and housing. And I'm struggling to see how then I could see what's been impactful in terms of adolescents who are not either in those considered sex workers or incarcerated. So I know that's a mouthful, it's a lot, but I'm trying to grapple with how can we begin to understand the impact of structural interventions on STIs and HIV, and then how might we begin to look at this in other populations. Thank you.
Yes, that is the difficult question. I mean, I think right now one of the strategies is, to look at, say, policy variations. Mark Hatzenbuehler does some really interesting work where he looks at, different, across the United States, different policies that might be associated, that might have implications for, say, stigma among men who have sex with men or immigrant communities. And they suggest, much lower, they suggest higher rates. He also did an interesting study on incarceration, and in neighborhoods that were, I don't know what exactly, if it was neighborhoods or what exact level of analysis, but that had higher rates of incarceration. There were also much higher rates of, STIs. So we have those kinds of ecological assessments, whether they signify that, those particular policies have health-related impacts directly or not, is not clearly evident from those kind of associations, but certainly suggestive. The thing is, it's really hard to evaluate a change because it's hard to, kind of control. But it seems like it's also the case that, we don't often necessarily try. So this is one of my reasons why I think maybe focusing on keeping youth, some sort of intervention to keep youth out of prison could be, because we see in our data that there's especially of the different aspects of incarceration that seem to be most associated with HIV and HIV-related risk behaviors, having a juvenile conviction is one of them. And it's not hard to understand why, because if you do, it's more likely that you're going to continue. These things sort of circulate. And so it would be an interesting type of intervention that could be possible to implement kind of at a local level. But getting funding from NIH or something like that to do that would be, highly challenging. The other thing that I'm thinking about because of the paper we did on STIs and evictions is, and this could also be something that you could implement at a more local level, would be some sort of eviction prevention type of program. So it seems like there's some areas where there might be some possibilities. Then the challenge would be getting the funding to the study, which could be another structural intervention. Like how can we change NIH's, for example, way of thinking about funding intervention research that's focused on social determinants.
Thanks for those talks. So I think it'll be pretty easy to convince. I don't want to speak for the committee, but I'm convinced that structural interventions are important. So, but how do we? I feel like we're going to get mired in, is it an employment intervention? Is it a housing intervention? Is it decriminalization? These are all sort of linked and overlap. You mentioned the drug use and the. So you said overlapping Venn diagrams. How do we think through those issues so we're not kind of like competing against, they're like trying to winnow out which intervention we should focus on?
Well, as you can see, I didn't choose one intervention, which is why we chose this full service drop-in center that had kind of scaffolding of core services, and then we added services as they presented themselves. We had no idea that we would need the robust food pantry that we needed. So I think, we have to start with something and not nothing. There was a group in Canada, but we also, this notion of hunger, the fact that so many women experience hunger every week. My own sleep led me to talk to a sleep researcher, and then all of a sudden I realized when we're out on outreach, we see women all the time that are like zombies. People don't sleep for days. One of the services that we provide at Spark is that we have couches where people actually can fall asleep. You can only imagine when a person's not sleeping, what it affects their waking hours, and also how the safety of women sleeping in abandonmeniums, et cetera. So even addressing basic needs, and I think it's really important to document those basic needs like hunger and sleep, because it humanizes people, let alone their STI risks, let alone how they're making money, let alone what drugs they use. So I think whatever piece of it we can intervene on and start to kind of target these points in the broader structures that really impact their risk, it's important. And even those basic necessities, why I make a pitch for that, because I think we often don't think about those basic necessities, and it's not something that typically is funded, hunger and sleep, in studies, of HIV and STIs.
Yeah, I was just going to say something to that as well. I mean, I think those are important questions. But on the other hand, I think, providing as much in the way of comprehensive services and, whether it's services or other sorts of interventions that can address a variety of different issues. But on the other hand, part of me feels like, why is it necessary, to get is there like the smoking gun is one of these, or are all of these? And you're not going to be able to solve everything with one intervention or targeting one area. So why does that become the thing that therefore, the reason therefore we can't try something? I mean, I think all biomedical interventions, they're all recognizing that they're only addressing a part of the problem, but they're addressing some aspect of it. And it's sort of like, why do we have to, find the right one? We have to be aware that some approach to, say, providing housing might look different if it's for someone who's using drugs versus somebody who's has serious mental health problems or whatever. So we have to recognize how the provision of any given or the development of any given intervention may vary depending on the type of users. But it does seem to me at some point that is it really necessary to have to find the exact right thing to target when we know that all of these things are complexly interconnected.
Thank you. Very important presentations. A question for Susan. You mentioned some tension between the health department and the program, or at least that this finding that in your program you find other women or other folks that they are not seen in the health department. Is there anything that you think that health departments could do, also kind of in a structural way, to enhance the access to them?
I think, it's also what researchers can do. So, there are a lot of famous studies that have come out of Hopkins and we're in the middle of some of the highest rates of infant mortality and overdose. So I'm going to put that burden on us as well. It's not just the health departments. That was a little, maybe I didn't have enough coffee. It may have been a little dramatic, the point. It happened to be one person who was working in the STI realm who we were just kind of surprised didn't know about what we were doing. And I think it's just important to always feed our data. CFAR has been a great way. We work closely with the health department, making presentations, trying to lend our statistical savvy to help them with data. I think that, for us, like at Spark, a few of our providers are from the health department. We have another grant developing an intervention for PrEP among these women, 80% of whom had never heard of it when we first asked them about it. And that's through money that a collaboration with the health department. So I think working with local health departments, being really creative with collaborations, both of these institutions are kind of behemoth to get approvals and funds. I mean, the structural barriers to having contracts and direct funding and et cetera, Charlotte's shaking her head, are huge. The whole STI, all the STI clinic staff at the health department are actually employed by Hopkins because of barriers. So I think even to that level, it's important to make sure that you can collaborate and be very persistent with some of the institutional barriers for working together. That makes sense.
Thank you. Brief questions, brief answers. Patty.
Sorry.
Oh, I'm not sure this is brief, but so it seems like structural interventions are the opposite of the magic bullet. They're very multi-pronged and very complicated and take a long time. So how can you give us some advice? How would you go about prioritizing? If the root cause of most of the issues is probably racism in our country, then how can we prioritize that?
For me, I see that doing something about the mass incarceration, because I feel like that is currently in our contemporary society a structure kind of in broad terms that really undergirds racism right now and brings, and to some extent there's also gender and class mixed in there. And so for me, that's why I've kind of turned to that, that literature and that understanding, that whole phenomena broadly defined as a place to kind of challenge. But others may have different analyses that would direct them in different ways.
Thank you so much for these presentations. As a provider of for women living with HIV, street sex workers, young women who come for family planning, I have concerns with priorities, because in the life of women, pregnancy prevention is the top, and then the rest, other than survival with food and all of that. And I'm seeing a parallel with the use of PrEP and long-acting contraception, where you have something that's very powerful and effective for pregnancy, for example, the long-acting agents, and then you might have risk for STD or evidence of STD because women feel that they are okay with the pregnancy stuff. Same thing with PrEP. You're protected from HIV, and then the rest is not a priority. Within, and I know these are sort of personal decisions or personal perspectives on our patients and clients, but how can, from the structure point of view, can you address these priorities that people have that might probably need more awareness of additional strategies? How can we, is there an intersection between these personal priorities or concerns and things that we can do to actually protect them from?
We work with, the busiest day is around buprenorphine. It's not around, it's funny, our least busy provider, although now she's starting to do PrEP, is around reproductive health. It's just now the women are on average a little bit older. It's harder to get adolescents and young women who think they're invincible into the doors of Spark, although yoga's brought younger people in, which is great. But for us, it's really around kind of needing a safe drug supply. Decriminalization would be my answer to your question, by the way.
So thank you for your comments in your talk. There was a recent NAS or National Academies report on permanent supportive housing. And their conclusion was, I'm just reading from their summary, that overall, except for some evidence that permanent supporting housing improves health outcomes among individuals with HIV/AIDS, the committee finds that there is no substantial published evidence as yet to demonstrate that PSH improves health outcomes or reduces healthcare costs. So my question is that, in some sense, what is the evidence? I know it's very, like, there's a lot of intuitive appeal to structural interventions, but there's kind of this, on the other side, you know, and it's in some sense more difficult to test structural interventions, but in other fields there's kind of this scientific standard that you need a randomized control trial or something like that to be real kind of evidence that something works. So I'm just curious that from your perspective, you know, how strong is the evidence? What is the evidence that structural interventions actually work in improving health outcomes?
Well, I think, you know, the one thing I would say about the permanent supportive housing, housing can be provided in a lot of ways, and access to housing. And even if it's the case that research might suggest that permanent supportive housing doesn't have the outcomes, in addition to kind of looking at how the study is done, it's also the case that perhaps that's not the form of providing access to housing that would have impacts. So I think that's one thing to kind of consider, that it's not that there's, you know, anything wrong with permanent supportive housing, and it may have a lot of other health impacts that are good, even if it's not related to HIV or STIs. But I think, you know, that's one question that could also be raised. Are there other ways of providing access to housing that might have better impacts? I know that doesn't answer necessarily the question directly of how to assess structural interventions generally, but with that particular, that would be something I would say.
Just want to add one thing. I think it's important. I haven't seen that report. That's interesting. There are many more studies that identify structural vulnerabilities than there have been interventions to evaluate. So housing comes up in any model of any outcome we have: violence, overdose, housing instability, because 60% of the women in the Sapphire study have been unstably housed in the past 3 months, an average of 2 places they've stayed. You cannot imagine that that's good for health.
No, that's exactly what this committee finds. So there's a lot of intuitive appeal or theoretical support and a lot of evidence that housing is correlated with poor health outcomes, and poor, not just health outcomes, but poor outcomes more generally. But when they actually try to look for interventions that improved housing or provided housing in any form, they didn't find, and that doesn't mean that it doesn't work. It was just that there isn't enough evidence right now to show that it works. And I'm just curious that we'll be tied by some of those same standards when we make recommendations about what works or not. So it's kind of important for us as a committee to grapple with what is the evidence out there, despite all the intuitive appeal of addressing structural problems.
Last point, Sean.
A question, and this is also priming for Jose and perhaps Liz's talk later. So question, could smartphones and social media be integrated into surveillance and structural interventions across all populations? You know, there's been a lot of work around MSM, for example, but female sex workers is there. I would imagine a lot of smartphone use and internet use. No?
Everyone talks about their Obama phones. Part of our PrEP intervention, we developed this very creative and rather expensive component that it was an mHealth component besides peer navigation. And about a third of the women so far uptake that because they have stable phones. People don't have money for phones. These women are recruiting people off the streets, so the phone doesn't mediate their being called. Much more likely in a sample, probably in Chennai, India, to have like steady cell phones that are on all the time than in Baltimore. That isn't to say that it's not important and still something that we continue to want to employ and explore, but people don't have steady phones as much as you would think.
And what about other ways to like, we found a lot of use around homeless youth, but going to libraries, or what about other types of internet access?
It hasn't, I think it's important. We have a computer lab for that reason, and there are always people sitting at the 3 computers at Spark. I think that it's an important world to introduce people to, but I don't know of studies in the US that have really used that as a form of health education.
Yeah, as a hobby, I go to public libraries, and you know, in Boston, in Chicago, in New Haven, in New York, it's just remarkable how many folks are at these vast computer banks, many of whom look homeless to me, look like they're people in need, and that is their anchor. So that would be a very important topic to study, because you're telling me we don't have any data on it, but observationally, a lot of libraries have gotten rid of their books and their vast computer centers. Okay, on that note, I want to thank our speakers very sincerely.